Next 9 minutes, we're going through some of the important artifacts which deal with OCT imaging. As with any other imaging modality, artifacts are common with OCT imaging. It is important to interpret them correctly to avoid mistaking them for actual pathology. Common OCT artifacts are related to imaging technique, image processing, imaging catheter and guide wire related artifacts, stent studs, and eccentric wire position. There are two artifacts which are related to imaging technique. The first one is obliquity or eccentricity artifact. We all know cross-sectional imaging of the vessels occur perpendicular to the imaging catheter. Why it is not showing? We all know cross-sectional imaging of the vessel occurs perpendicular to the imaging catheter. When the imaging catheter is in the center of the lumen and parallel to the long axis of the vessel, it results in a circular nice image. However, when you are in a large vessel or in a curvature, the catheter alignment is non-coaxial and the resulting image appears elliptical. What is the clinical implication? This makes your measurements inaccurate. Somebody can help me with the post to this thing there, this interview. It's not coming in full screen. No, it is not coming in the full screen. No, it is again. Somebody.
Promax, you have to do more than wave. Help him out with this presentation, please. Why don't one of you come to there are three of you there. One of you can come here.
So the clinical implication of obliquity or eccentricity artifact is the measurements you make are inaccurate. The second artifact is the blood clearance artifact. So you need high viscous solutions for optimal blood clearance. When the optimal clearance is achieved with high viscous solution, the lumen appears dark without speckles and the vessel wall appears bright. When you use low viscous solutions like dextran or saline, there are leftover RBCs and the lumen appears as speckles. When the blood clearance is suboptimal, there is mixture of contrast with blood products that results in blood cells of varying shape. So this is the typical example of blood cells. At the end of the injection, when the contrast clearance is inadequate, the residual blood produces appearance of a thrombus. So this is a typical appearance of your artifact similar to a thrombus. There are three artifacts which are related to image processing. The first one is non-uniform rotational deformity. The optical lens rotates at a constant speed around the circumference. That results in the cross-sectional image. When there is a variation in the rotational speed of the optical lens along the circumference, that results in smearing within the arc of the circumferential OCT image. Usually it occurs in vessel charge sparsity, tight stenosis, heavy calcification, or equipment imperfections. You can see the structures in that part of the circumference that limits accurate cross-sectional measurements. The next artifact that result from this thing is SUOP or seamline artifact. For a cross-sectional image to form, the catheter must remain in the same position till optical lens rotate around the circumference. If the image wire or artery moves before the completion of the circumferential image acquisition, a single radius of malalignment occurs in the circumferential image. That is called SUOP or seamline artifact. The next artifact is fold-over artifact. FDOCT has a field of view of approximately 10 millimeters. When the light is reflected from the areas of the vessel beyond this field of view, aliasing occurs in Fourier transformation that gives the appearance of far field area of the vessel folded over in the image. These artifacts occur commonly in large vessels at the sites of bifurcations, particularly the left-mind bifurcation. Clinical implication, portions of this image that contain the folded artifact should not be interpreted. There are two artifacts that are related to image catheter and guide wire. The first one is the wire shadow or bubble artifact. The guide wire and the small bubbles in the imaging catheter results in reduction in the signal intensity by shadowing beyond the structure. This is the guide wire related. Second one is air bubbles that result in a reduction in the image quality. Okay. The next artifact is the multiple reflection or ghost lines. So repetitive reflections within the facets of the imaging catheter produces one or more circles centered around the imaging catheter. If you misinterpret these coastlines and make your calibration, measurements will be artificially smaller. There are 5 artifacts that are related to stent cells. We all know stent cells are highly reflective structures. So all the light photons get reflected from the surface, so you'll be able to see only the leading edge. Hence, you cannot assess the true thickness of the stent cells. In addition, they cause shadow behind the stent cells. They obscure the details on that part of the vessel. And the next one is saturation of the detection electronics causes spillover effect into the nearby low-intensity pixels along the A line. That results in blooming or oxide thickening artifact, which makes identification of the true leading edge difficult. When the high amplitude backscattered signals from the stent cells saturate the processing limit of the detector, you get an abnormally bright A lines in the image that is called saturation artifact. When there is a repetitive reflection between the stent cells and the imaging catheter, ghost studs at multiple distances that are centered on the imaging catheter happen, that is called reverberations. Clinical implication, they should not be mistaken for multiple stent interfaces. There are 4 artifacts that are related to eccentric wire position. Central position of the catheter is important for optimal light-tissue interaction. When the catheter is very near or touching the vessel wall, that results in artificial increase in the brightness of the tissue adjacent to the eccentrically positioned imaging catheter, most often misinterpreted as fibrous cap or macrophage accumulations. The next artifact is tangential signal dropout. When the catheter is centered, the light interaction is perpendicular, and that results in optimal image quality. When the catheter is close to or in contact with the vessel wall, the incident light rays are tangential, are parallel to the surface of the vessel wall rather than perpendicular to it. So they do not penetrate into the deeper tissue. That results in artificial signal attenuation in the deeper part of the vessel wall. A signal-rich surface and attenuated deeper tissue, this gives false appearance of thin cap fibroathyroma. The next artifact is sunflower artifact. Again, images are reconstructed perpendicular to the imaging catheter. When the catheter is in the center, the light interaction with stent cells is perpendicular. That results in normally oriented stent cells. When the OCT catheter is eccentrically located in a stented vessel, the incident light beams are not perpendicular to the stent cell. Instead, they get reflected from the edges of the stent. The resulted images are reconstructed, orienting perpendicular to the catheter, similar to orientation of the sunflower towards the sun. This sunflower effect gives appearance of stent malapposition that artificially increases the apposition distance between the stent cells and the vessel wall. The next artifact is merry-go-round effect. When the catheter is in center, the lumen is clear, studs are of uniform width. The merry-go-round effect is an apparent elongation of stent cells in the lateral direction. It occurs due to 2 reasons. One, eccentric catheter position. That results in reduction in the lateral resolution in the far field, or the large beam spot in the far field. So that results in an artificial elongation of the stent cells. It can also occur with the catheter in the center position. This animation is moving very slow. When there is optical scattering in the lumen, primarily due to inadequate blood flushing between the catheter and arterial wall, which causes the backscattered light from stent set to appear to be originating from a wider length than the true length. So that again results in artificial elongation of the stent sets. Thank you.
Wonderful presentation, right?
Thanks.
We have to know all before we start LCT. It's very important.
One word where we are going. The more and more we are seeing automatic assessment. And we are starting to pull back and we are seeing a lot of flags and the people are jumping immediately, say approve. And then when we are moving toward, for instance, the coated balloon, we can imagine immediately how much we are going to distort the lumen, how much will be in the future very critical to get the differentiation of what is true compared to the artifact. Do you have an idea how we needed to work in the future for getting immediately identifying this more important artifact that they are coming in decision making?
I think it's a fascinating question. Go ahead, Vijay.
No, I didn't understand.
So
Sorry.
what he said is that soon we are going into, automated assessment of all these things. So do you have any suggestion to try and decrease the occurrence of these artifacts, or can we kind of find some way to get past them so that it doesn't confuse the machine when it's trying to read what's happening?
Maybe I'm not very sure whether the artificial intelligence make any difference in reducing the artifacts. Maybe it improves differentiating between true structures and artifacts. Maybe Jihad can enlighten on these things. I'm not very sure about this one.
Yeah, I'm not sure. I mean, AI is based on a ground truth, and ultimately what we would have to do is just see a number of cases and train the algorithm that these are actually artifacts. I think there's some value to that, but I mean, first of all, this was a wonderful presentation, the first of its kind. But one of the things that the relative clinical impact of these artifacts is relatively small, right? The main ones are basically nerd and chatter. Those are the two things that are presented commonly that actually impair us from being able to make a clinical decision. And those can't really be trained by AI because they're actually mechanical faults rather than image interpretation.
Do you have a comment?
I think that is what is going to be in the future. Instead to take in and out, we are going to see very carefully the A line going around. To get excluded only the artifact that they are piece of the entire circumference. That is going to be very important. So instead to go yes or no that is an artifact excluded or taken into account, we are going to use the best of the technology that is based upon the A-line techniques. That is for AI.
Fascinating discussion.